So let's start immediately with Emmanuel. So Emmanuel, in a situation of community-acquired pneumonia, please explain to the audience how to use, if we have to use, glucocorticosteroids.
Thanks for the invitation. Okay. So here are my disclosures. So why to use corticosteroids during community-acquired pneumonia, referred to as CAP? First reason is that the burden of community-acquired pneumonia remains high despite high mortality, appropriate use of antimicrobials. It is the leading cause of death due to infectious disease. It is the 8th most common overall cause of death worldwide, and mortality of non-ICU inpatients is between 10 and 12%, and it can be up to 30% in ICU patients. The second reason is that inflammatory response has been shown to be a major contributor of CAP-related mortality. It is true for systemic inflammation, and here you can see that when we measured plasma levels of cytokines in patients, the mortality is higher when the plasma levels of cytokines are elevated. And what is interesting is that using corticosteroids, some studies have shown that you can decrease the cytokine levels in CAP patients. It is also true with local inflammation. Here it is a model of piglets with Pseudomonas aeruginosa pneumonia, and adding steroids to the antimicrobials can decrease the cytokine levels in these piglets. We are lucky because we have several randomized controlled trials that assess the efficacy of steroids in this context. Here I will show you the two most recent meta-analyses. The first one is from the Cochrane Library, published last year, including 11 RCTs from 1972 to 2015, and they showed several potential benefits. A decrease in mortality, and this is important only in severe CAP, but also in the whole population, a decrease in early clinical failure, in the time to clinical cure, and a reduction also in hospital and ICU length of stay. They only show a few arms, an increased rate of hyperglycemia, but no effect of secondary infection. And also, it's important, they showed no impact of the onset of RDS, septic shock, or COPD on their results. The second meta-analysis has just been published last month, including 6 RCTs, the most recent one with the best quality, from 2005 to 2015. And what is important is that it included individual patient data. So they also show several potential benefits, a discrepancy on mortality, no effect in this meta-analysis, we'll comment that after, but also a reduced time to clinical cure and a reduction in hospital and ICU length of stay. They also show a few potential harms, an increase in CAP-related rehospitalization, an increased rate also of hyperglycemia, but still no effect on secondary infection. And importantly, they show no impact of disease severity and no impact of inflammation as measured by CRP or SAIS criteria on the results of the meta-analysis. So how to interpret these discrepancies? It may be due to an heterogeneity between RCTs and to an unequal quality of randomized controls trials. On this table, I showed you the most recent RCTs, and you can see that the number of patients included and the inclusion criteria were highly variable. In some studies, they included severe CAP, in other one, only hospitalized CAP, and in the study of Torres right here, only severe CAP with high CRP levels. There was also a huge variability in corticosteroid regimen that were used and in the duration of corticosteroids. And it was also very heterogeneous concerning the primary outcome that was assessed. In some studies, it was the oxygenation. In others, it was mortality or clinical cure or hospital length of stay. Finally, there was a big heterogeneity between the risk of bias. In some studies, there was a high risk of bias, as this one, for example, and in other one, the risk of bias was more limited. And this risk of bias is important because if we go back to the results of the meta-analysis of the Cochrane library, they nicely showed that if you only include studies with a low risk of bias, you find no impact of corticosteroids on mortality. But if you include all the studies, including the studies with high risk of bias, you find this reduction of mortality by corticosteroids. So what is the conclusion? We have shown conflicting results. What is sure is that there may be a clinical advantage to corticosteroid, mostly in patients with severe CAP. There is an uncertainty still about the effect on survival. This uncertainty may be due to limitations of these RCTs. The most frequently regimen that was used was equivalent to 50 milligram IV prednisone equivalent, and the duration was between 5 and 10 days. The effect of corticosteroids in severely ill may be due to an effect on IRDS or septic shock. We don't know, actually. What is sure is that you have to avoid the use of corticosteroids in case of influenza suspicion, and maybe in case of diabetes, that's less sure. And finally, we have to wait for other results. There is the Cape Cod study that is ongoing before definitive recommendation.
Thank you very much, Emmanuel. So I will start with a question from the audience. So what about the immunosuppressive effects of glucocorticoids in community-acquired pneumonia and other severe infections?
Actually, in all the RCTs, none shown any effect on the recurrence of infection or on nosocomial infection when you give corticosteroids in this context.
Yes, I fully agree with you. I don't know what is the advice from the other experts, but with these, with the 50 milligrams, for example, of Solimedrol, or with the use of hydrocortisone, we'll come back to that. I'm not sure that there is any immunosuppressive effects, considering that these diseases are diseases with a huge inflammatory response, and we'll come back to that in the other talk. But I fully agree with you.
I think we should make the difference between immunosuppressive effect and immunomodulatory effect.
Yes, I agree with that. But what would be your advice to use corticosteroids in the context of community-acquired pneumonia as an expert? Only in severe pneumonia you will take a biomarker like CRP, or you will use it for all the community-acquired pneumonia? What is your feeling about that? Even if we don't have the definitive answer to that.
I think I fully agree. I think we should only use it at this time. Before we should wait on further study, but at this time we should only use it in severe pneumonia. Mm-hmm. How to assess the inflammatory response is an issue, but for sure there is strong rationale to only use it in severe pneumonia with a strong inflammatory response. It was done using CRP in the RCT in one of the two most recent RCT, the one that was published by Torres, and with nice results. It's one of the last RCT. It's one with a good methodological quality, and with no results on mortality, but a nice result on clinical outcome.
I agree with you, because the three last multi-center randomized studies, the primary outcome was not mortality. It was a composite outcome, as you shown in your slides, of mainly clinical cure with or without inflammatory marker, but it was not mortality. And in these three studies, two in the Lancet and the one, the very nice paper of Torres, I feel like the results were quite good in saying that we can use moderate dose of corticosteroids in a community-acquired pneumonia, severe, probably, I agree with you, with a good safety profile. And it seems that the clinical cure is better with than without corticosteroids. I don't know if the other experts agree with that, but I think this is a balanced message to the audience.
Yes, I think the trend is going toward the use of corticosteroid in this kind of patients. But one of the questions, open question, is the perfect timing to initiate the corticosteroid. Because if we wait for the patients to become very severe, perhaps we will be too late. And but we shouldn't probably not treat patients with no severe community pneumonia. So it's a big question. What is the perfect timing to treat patients?
I'd like to make two comments. The first is related to the audience questions about immunosuppressive effects of corticosteroids. Just to mention that back in 2009, there was a very elegant experiment from a group of George Crusoes published in Française journal, where they incubated monocytes from human being with dexamethasone and looked at the genes expression. And what they showed actually is that the cells were not immunosuppressed actually. There were many more upregulated genes than downregulated genes. And of note, the genes that were upregulated, most of them were related to innate immunity. And those who were downregulated were related to adaptive immunity. So that, to me, suggests that in the context of sepsis or severe infection, it's very unlikely that the corticosteroids regimen that we are using in practice may have suppressive effect. Related to the use in CAP patients, so clearly the trial from the Netherlands, the trial from the Switzerland, they looked at patients hospitalized outside the ICU. And in this group of patients, what really matters for physicians and patients and family is length of stay in the hospital, because they don't die. And what this study showed, actually, they showed a remarkable reduction in the duration of hospitalization. And that was valuable for the patients, for the physicians. So my guess is that also in non-severe hospitalized patients with community-acquired pneumonia, I would suggest that these patients should be receiving corticosteroids.
Thank you very much, Djilali.